Hello everybody, good evening. My name is Jessica and I work for the alumni team here at King's, and it is my pleasure to welcome you to our King's Expert Series webinar tonight, which is all about how digital technology can support the mental health crisis. We have a fantastic panel lined up for you who will be sharing their expertise, and in the second half of the webinar you will have your chance to ask your own questions to our panel by using our Q&A function. Without further ado, I'm going to hand over to Professor Richard Trembath, who will be taking the role of chair this evening. Thank you, Richard.
And thank you very much, Jessica, and may I convey my own welcome to all who are joining us, and perhaps in no way a surprise, we've got a very significant audience online with us this evening, and as you know, this will also be recorded and shared with a wider audience beyond. My name is Richard Trembath. I hold the role of Senior Vice President for Health and Life Sciences here at King's. I am an alum, and I also hold the role of Executive Director of our Academic Health Science Centre, King's Health Partners. And you will be aware that the interplay between mental health and physical health is a very significant component of what King's Health Partners focuses on. But this evening, we have an opportunity to think about and discuss elements of the impact of digital technology and mental health. And I am hugely grateful and delighted that I've got real expertise in our panel, and expertise that covers a number of different domains that are relevant to the discussion we're going to have. So without further ado, I'm going to invite my colleagues to briefly introduce themselves, but also say a little bit about the area and relevance that they hold for the broad topic of digital technology and mental health. And if I may, can I invite you, Faye, to introduce yourself?
Yes, thank you very much, Richard. I'm Faye Bound-Alberti and I'm a professor of modern history. I work on the histories and meanings of medicine, emotion, and the body, and most recently on the origins of loneliness as a social as well as an individual emotion. And of course, loneliness has been called a modern epidemic. I also work on face transplants and technologies of the face with a major grant for a project called Interface. And I work with psychologists, surgeons, patients, psychiatrists, ethicists in 9 different countries. I lead the Digital Futures Institute Centre for Technology in the Body. The Digital Futures Institute, or DFI, is concerned with how we live well with technology, and it offers a unique arts and humanities approach to what are normally regarded as technical challenges. And the Centre for Technology in the Body is a reminder, I think, that however digital we become, we are always going to be embodied beings.
Thank you, Faye. Can I move now to Till?
Hello, I'm Till Wykes. I'm a professor of clinical psychology and rehabilitation, and I'm also the head of the School of Mental Health and Psychological Sciences. And really, it's tough to speak without pictures, but I want to tell you really about what I do and where digital health is really important in terms of what people have called the mental health crisis. So my own research is on cognitive skill improvement, building technologies called cognitive remediation. That's starting in schizophrenia because we know the problems limit the effects of recovery. And so if we can intervene to improve cognitive skills, then maybe we can help to improve recovery, which will help the NHS with the costs and also allow people to obtain their personal goals. We do all of this, and particularly within psychology, we develop digital therapies, both apps and web applications. And I've built one called Computerized Interactive Remediation of Cognition and Thinking Skills, which is far too long to remember. It's actually called the simpler way as circuits. But we also do things for people with mental health conditions, so with specifically anxiety and depression, but we also use those therapies together with people who have physical health problems as well, because we know that mental health difficulties really do affect the outcomes for physical mental health problems. I'll talk a bit more about apps and web applications if anybody cares to ask me. But going forward, we're really expanding the kinds of technology we use, particularly using virtual reality and avatars in our research. And we're soon to be thinking about how we can use the data we collect in the back end of all of these applications so that we can think a lot more about how to personalize treatments. And I'm passing on, I think, to Matthew, who's going to talk a bit more about that big data.
Thank you, Till. Over to you, Matthew.
Thank you. So I'm Matthew Hosoff. I'm a psychiatrist and epidemiologist, and I'm now Executive Dean of the Institute of Psychiatry, Psychology and Neuroscience. But I've been in this space for a little while, and I'm very pleased to see so many of you here. I guess the way I've thought about it is that mental health, there are a number of challenges, but let's really simplify it and say there are two big challenges. And one is about developing new treatments to be able to offer people with a wide range of different conditions. And, we talk about mental health as though it's all one thing, but it's not. It's multiple different conditions across the life course, which have, varied and different effects on people. But fall under that remit, and there's a need for new treatments. It's absolutely clear. We've the drug treatments have been successful up to a point, but they've only got you so far. Types of therapies are difficult to scale, and it's absolutely essential that we develop new ways of providing treatments to people. The other big challenge, I'd argue, in mental health is addressing population need, which is about making sure that the treatments we develop are actually available to people, that the right people get the right treatments at the right time, and that we address problems like prevention, which has always been a challenge in mental health, and also access to care. And access to care for the people who need it most. So those are the sort of things which I'm thinking about in terms of as Dean of IOPPN. And in a way, the digital area is a set of tools which allows you to start addressing some of those. And we've been doing this in terms of the data which are available. And of course, we've had a digital revolution in terms of the sort of scale of data which is there, data which is generated by healthcare systems through electronic health records, but also from increasingly pervasive technologies like smartphones and wearables, which potentially tell you a great deal about someone's day-to-day life. So we've been working a lot on the way in which those sorts of data streams can actually be informative about people's health, and then thinking about the way in which that information can be used potentially to intervene, whether that intervention is digital or is some other form of intervention. But that's kind of the vision and where we see ourselves.
Well, look, thank you, and thank you for being concise, but we'll obviously draw out and expand on some of the things that you each have alluded to. But just to extend the conversation, I would like each of you to comment on this. That and look, the fact that we have got so many folk joining us this evening tells you this is an area of considerable interest, and society in general is very focused on, some may say dominated by and through digital technologies. What I think would be interesting, however, is to understand from each of you in your areas that you are working on, how do you draw upon the societies that are relevant to your areas of interest in the way that they shape and contribute to the research in particular that you're undertaking? And how do you ensure that you're drawing across a breadth of society, whatever society means? How do you bring in that sense of diversity, which has to be relevant when any new technology or new instrument is being developed. It'll be different in each of your domains, but perhaps you might offer some reflection. I probably think I will go in the same order that we started and invite Faye to perhaps offer her initial comments. It will be somewhat different to where we'll end, but I think it'd be helpful to hear your initial thoughts.
Yes, thank you. I think that the question of diversity and equality here is incredibly important because, as we all know, despite expanded access to a range of digital technologies, it's often inequitable in its distribution. And we need to find ways of making sure that there is a high quality that is provided across the board. I think if I would take, for example, my work on loneliness, one of the most important things that we are interested in from an arts and humanities perspective is language. We have a language of an epidemic of loneliness, which I think takes us away from some of the complexities involved, some of the cultural complexities involved. To understand how loneliness impacts people at different life stages, for instance, and different demographic groups, we really need to understand loneliness as a cluster of different emotions that affects people at different times. And a lot of the work that I've been doing on loneliness, particularly during the pandemic, where people were isolated, is really teasing out some of these cultural differences between being alone and feeling alone, choosing to be lonely because one actually enjoys quietness and contemplation and solitude, and all of those wonderful things that we think about in terms of introversion and wanting to be alone, and actually enforced solitude because of social inequalities or health inequalities. And one of the things that I found quite striking during the pandemic period was the emphasis on the development of a loneliness pill. And to me, that is deeply problematic because a pill for loneliness is simply addressing some of the major symptoms of loneliness, which actually were roughly similar to the symptoms of depression and anxiety. So although I understand that this is a quick fix, it's not addressing the causes, which are very much embedded in social inequalities and how we live. And as a historian, I think it's really important that we are able to tailor our understandings of what conditions are, how they've changed over time. In the case of loneliness, it's only really emerged from around 1800 as a concept, at the same time as urbanization and a breakdown in traditional forms of community. Well, that feeds into the kinds of approaches we would want to offer. And I think here this is important in terms of digital technologies because we all experience things like Zoom during the pandemic. And while it's wonderful and can provide opportunities like this, and we can all get together in a virtual room, there's also something really missing about the physical experiences of being with people, the sensory experience, the smells of the coffee shop and the sounds around you, and the physical experience of being connected to other people. And that's something that is interesting in digital technologies that are designed to prevent loneliness is have yet to be addressed. So you have bracelets that vibrate when someone's thinking of you, or t-shirts that hug you, and yet we cannot yet reproduce that physical experience of being with another person.
Well, thanks, Faye. It's a very interesting perspective. Till, can I again just draw on your thoughts, and I know you are very thoughtful of how to engage with populations, patients, societies in the development of elements of digital technology, but also in the context of, there is no one single population. We deal with different and very diverse populations, and how we will need and how you are thinking about that.
Okay, well, I suppose there's two main aspects. You mentioned, Richard, the development of digital technologies, and of course they really need to be developed together with those people who actually are going to be using them. And that's certainly one of the things that we've done a lot of at the IOPPN. We have actually got a group of researchers with lived experience, which is a great help, but that isn't enough. If we're going to co-produce some of these digital technologies, we need to involve people right from the very beginning in the thoughts about how you develop them, what is the actual problem that they're trying to solve, not the one that we would like to solve, and also how the digital technology is provided. Well, actually, I've got three things now because Faye suggested one extra. So the other issue, of course, is in the, thinking about diverse populations, especially the one in South London. We have a lot of people, as we learned during COVID, well, and as some of the research that I've done as well, people may have smartphones or they may have a phone, but they share it with somebody and they don't have very much data. So if you're going to provide digital products, you need to make sure that people have the opportunity of access to those. And certainly SLAM has made great efforts. That's South London and Maudsley NHS Foundation Trust has made efforts to try and help people have access to digital products and data so that they can then take part. But there's another bit which Faye mentioned, which is the idea of having a person around. One of the things we've learned is that having somebody to coach you or any human contact while you are carrying out a digital technology greatly enhances the outcome of that digital technology. So despite the fact that there are now, I think, 75,000 apps for mental health issues, we know that there are very few of those, either have been tested and evaluated, but also that the suspicion is that the number needed to treat or open the app would have to be in the thousands before actually you manage to get somebody who would improve if you did it without any human involvement. So that coaching or therapy or training that a person who's involved with the digital therapy really does help. That's not to say that these are not great aids, but for some people, they may need to have some extra support to make them really achieve what we expect from these. So let's not hype them too much, I think.
Thanks, Till. Matthew, look, why does society need to take an interest in this? And how do we ensure that it's the breadth of society that can engage?
Yeah, so I mean, I think you can cut this in lots of different ways. If I, as an epidemiologist, when you do surveys, you tend typically to end up failing to reach the people you most need to get hold of for mental health, and we've shown that in lots of different studies. But I was involved long ago in a very, I mean, it wasn't really my work, but I got drawn in some very elegant work from Norway using data from standard surveys, and the people with mental disorders were the least likely to take part in a sort of standard health survey, and therefore you're often leaving people out. And in our local context in South East London, it's not just the people with mental health problems, but it's also the people who come from areas of higher deprivation and from from ethnic groups who are overrepresented in our services, but underrepresented in us in our studies. And so there's an element of this where some of the observational work in digital, particularly the use of routine health records and the linkage of those, is incredibly helpful because it actually gives you whole populations with denominators in a way which you just don't get from more traditional survey methods. So that actually allows us to really start identifying areas of greatest need. And some of my colleagues have done wonderful work in terms of, for example, linking health records to schools data. And that then tells you something about the schools in the area with the highest mental health needs, which is just of data you wouldn't be able to get from handing out questionnaires. It's far better at doing that. So digital can actually, these sort of digital technologies of using real world data can actually give you information which you just don't get from more traditional things. But of course, the other end of that is the digital divide, and the fact that some of the groups I'm referring to may be more wary about about sharing data, more wary about engaging in apps. And so the work which Till's referring to in terms of, really building up trust from the get-go when you're developing something which someone has to interact with is absolutely critical. And it's not just about the look and feel of the thing and how you promote it, but it's also issues to do with, of course, AI, famously, some of the AI applications are discriminatory because they're based on people with white skin. And they don't think about people from other cultures. So one has to build that in the design. The last thing I'll say is that sometimes you get results which are surprising. So a colleague of mine has done some fantastic work so this is a sort of problem of health generally, of not collecting outcome data on a routine basis. And in mental health, it's something which is patchy, but it's something really important. So a colleague has been looking at this in terms of mental health care in children and being able to routinely collect patient-reported outcomes in clinics and actually before people get to the clinic. This is the work Johnny Downs, a colleague, a child psychiatrist, has done. And he's developed an app called My Health E. And what it does is basically pushes out a notification which parents or the young person completes, and then and then the information comes back and is integrated in the health record. And it basically allows one to scale and get a much better indication of how someone's doing. And it's really crucial information if you're putting someone, for example, on medication for a condition like ADHD. And what they've actually found is that is highly accessible and people appreciate it. When they've monitored, and of course this is the thing you've got to do, you've got to monitor the data. They've actually found that the diversity data there is better than what they were doing before, using more sort of traditional pen and pencil, pen and paper type approaches to collecting information like that. So I think there's a lot to be gained, and it's, as usual, it's more subtle than just saying there's a digital divide and we've got to be worried about it. I think it actually, these technologies potentially give you something which is far more informative about population need and the groups we're most interested in terms of health inequalities.
Well, thanks. I'm going to just continue the discussion, but I did just want to highlight and just perhaps ask Jessica. The audience, in just about another 7 minutes or so, we'll be opening this up to questions from the audience, and so please do share any questions that you might have, and I believe those are going into the Q&A component. But Jessica, if there's anything the audience need to know, make sure that they are informed. But let's just continue for the moment with the wider discussion. And this, so we've talked, each of you has spoken about the potential, and of course it's somewhat difficult to predict, but things are moving incredibly quickly, and the unmet need is such that it does need to go at pace in the health domain, but in the applications more broadly. So perhaps again, and I would invite each of you to just briefly use your speculative lens, and starting with you, Matthew, what are the big things that you anticipate happening within 5 years? So each of you can have a go at that. But Matthew, your 5-year lens.
Well, so I think some of the relatively easy things to do are actually having well conducted studies with clear endpoints about developing new treatments for specific indications in mental health, which are digitally delivered. And I think there are a few key points here. One is, we've got a number of studies, I mean, that Till has alluded to, of digital therapies which are in the pipeline. It's a very big ask to get to the point where you actually prove efficacy and then get to the point of being able to take it through regulatory approval, and then licensed and commercialized and disseminated. And like it or not, the route to widespread population dissemination is through some kind of usually through some kind of commercial vehicle. But we've got examples of that. A fantastic example from our colleague Rona Moss-Morris on irritable bowel syndrome and being able to do that, being able to deliver a therapy there. So that's one side of it. I think the other side is being able to give, I think it goes back to this sort of use of mobile technologies to be able to get an indication of someone's health status and use that in a way which is actually meaningful. So we've run a study which was based at King's, but actually had many partners across Europe, called Radar CNS, where we're using data from smartphones and wearables to be able to actually try and predict health, and not just predict health, but tell you where someone was at. And we, there are many signals from that which are highly informative, and they tell you things which you can't get from traditional methods. So, classic kind of studies which we do in mental health, if it's neuropsychology, it involves quite a long session with a neuropsychologist, highly, that's expensive and difficult. If it's a sleep study, it involves putting someone in a sleep lab. That's very difficult. But actually, from these sorts of technologies, they're not providing gold standard information on sleep or cognition, but they are giving you something which you can do at a much bigger scale and much more cheaply on larger populations and get information which is useful. So one of our studies, which is currently under review, is looking at sleep patterns in depression and actually finding that the variability in your sleep is highly predictive of your likelihood of having a depressive episode. And it's that sort of information which then goes on to being able to intervene early in terms of being able to help someone with a disorder. Think about psychosis. If you've got people who are having an early symptoms of psychotic illness, which are picked up from a disturbed sleep pattern, and if you are able then to use that signal to be able to intervene early and perhaps prevent someone ending up in hospital, there's a huge value proposition in terms of health economics for that technology. So those would be a couple of examples.
Thanks, Matthew. Can I just perhaps, Faye, where would you think in your own field 5 years from now we will be?
Well, I think we will continue to see as many counselling services and AI-generated attempts to deal with mental health that we see now. But I am concerned that there's going to be a widening gap between the quality that's available. So that does worry me. In the field of face transplants, which is a hugely exciting area in which to work, and we haven't had a face transplant yet in the UK. There's been nearly 50 around the world. And I'm working with the surgeons involved in those treatments and with the patients to understand things about outcomes. And what I would want to see much more of, and hope to see much more of, as things pick up and there's much more emphasis on prosthetics as well as AI insights into patient-reported outcomes, is a better join up internationally. Because, of course, one of the things that we have to think about is not simply issues around regulation, but also issues about international join up in order to raise quality and have a better understanding. Most of the work that needs to be done for us to achieve those kinds of standards still demands a lot of legwork, effectively. So we need to be able to ask the right questions of people, which is the close attention to detail and the kinds of working with individuals that Till was talking about earlier, before we can leap to making big assessments based on AI interpretation. So I think we're going to see a lot of changes in the healthcare sector and a lot more accessibility, but again, a widening divide. And the opportunity now is for us to ensure that the quality is right.
And before I come to Till, can I just prompt you a little bit on who is this going to require, legislation to avoid this proliferation of and the indiscriminate use of apps that are thought to be of therapeutic benefit, or who should have ownership of this?
Yeah, I think that's a very good question that possibly Matthew is more placed to judge on it. I think, or Till, yeah, absolutely. From the point
all right,
of view,
well, look, let's see what Till's thought on that is. Thanks, Till.
Okay, so you asked for my 5-year view, and unfortunately I have too many cups of coffee with Matthew, so a lot of what he thinks is going to happen is what I think is going to happen, although he didn't mention the issue of new technologies. So there is, we have avatar therapy now, where voice hearers talk to an avatar, which is the embodiment of their voice, to try and take control over it. But we also have work in virtual reality. Virtual reality, I think, is a really good break between in the clinic work and going out and using skills which people have learnt in the clinic and using them out in the community, because it gives you a structured and more controlled environment in order to test, whereas in the community, opportunities for testing various skills kind of are hit and miss. So I do think the new technologies will come into this, but in terms of, and I sort of vaguely mentioned it when I said hype, one of the problems with apps on Google Play Store or on in the iStore is that you have to download them before you know anything about them. And I think that the pressure ought to be put on those stores to provide you with some information before you actually have to press the button to download something. If I go to Tesco's and I decide that I want to buy a packet of cornflakes, there may be 6 boxes. I can take them off the shelf and I can read the ingredients and make an informed decision. You cannot do that in the app stores. So I do think there's pressure on them, which may come from regulators, but also may come from people with lived experience using it, because we know that as people get more sophisticated about the use of digital technologies, they are going to refuse to use some which end up having no evidence of its worth. So I do think, that from the point of view of anybody producing digital technology, having information that you can provide immediately about how useful it will be is more likely to, and I sort of do this in inverted commas, sell the app, because really you're not selling the app at all. You're collecting data from the person usually.
Thanks, Till. Can I just now, to the audience, we'd very much welcome any questions you might have. I'd rather we did that through the Q&A channel rather than reaching back into the audience directly, so that we can try and manage them. So please, if you do want to make a comment or a question, put it in the Q&A and we'll draw that, draw from there, and we welcome that. I've got some further questions, or at least thoughts I'd like the panel to share back with us whilst you're giving some further thought to that. Look, we're amongst friends here. This is King's alumni, and I'm sure many of us would like to know why is King's particularly well placed to contribute to this, notwithstanding the expertise that we hold more broadly in relation to mental health. But this is quite a new dimension. So why are we well placed to make significant contributions that are of global relevance? And again, good to just sort of get a feel for this. Perhaps the 2 dimensions. Faye, you might want to sort of talk about this, and particularly in the context of the interdisciplinary requirement, and that may be reflected by others as well. But then, if I may, I'm going to go back to Matthew and understand why he feels, and what he's, and in his role as exec dean, feels he will need to do to ensure that we can continue to be at the forefront. But Faye, your thoughts first.
I think that King's is extraordinarily good at interdisciplinary collaboration, and we know that interdisciplinary work tends to result in innovative and exciting new insights. We had an event recently, for instance, in the chapel, at King's Chapel, which was between the IOPPN and the Digital Futures Institute, which was dance to understand. So it involved dance to understand through wearable technologies the experience of living with MS or the experience of living with depression. And so much, we had a conversation earlier about the importance of new technologies and what they bring. And as with most things, it's what we do with them. And those sort of intersections where we can come up with exciting new knowledge, they are the most important places to be. And King's is at the forefront of a lot of that. In particular, the Digital Futures Institute has centres like attention studies, Centre for Technology in the Body, digital law, digital culture, and we're offering this extraordinary interdisciplinary way in to thinking about living well with technology, which involves working all across the faculties. So I do think King's is, obviously an international leader in this space, but we have the people and the opportunities to make that happen.
Thanks. Matthew, the challenge I put to you. We're good. How do we stay good, and what's going to be required in order to do so?
Well, it is a very fast-moving field. I think the point about interdisciplinarity is critical, and it's also cross-sector. So, my own faculty at IAPPN is very proud of the sort of strong association we have with the NHS, particularly the Maudsley, and that means that many of us are grounded in clinical experience and work, and that informs our research, but it also means that there's an outlet for future dissemination and testing and so on. And I think it is absolutely critical, as Till has said, that you involve people with the experience of these disorders from the get-go in order to have credibility. And if you look at the digital industries, it's quite interesting. I think the digital industries have failed to make as big an inroads into this sort of space as they might have expected to. And the reason I would argue that's the case is partly a lack of insight and knowledge and real depth of knowledge about what the conditions are that we're talking about. And it's also an issue of trust. And so what we have through these partnerships between the research and the service, the university and the NHS, is trust and credibility. And I think that is something which is incredibly precious and something you have to kind of absolutely guard. And guarding it is sort of ensured by the fact that you do a lot of due diligence. You work very hard to ensure that people are involved in all stages of product development. And I mean, Till does this supremely well. But in our research studies, we ensure that our patient advisors are authors on publications and are there really taken seriously as part of that process. So I think that's one key element. The other, but I think bringing back industry, this is probably the thing which most important to happen in terms of dissemination, but being able to draw that out from us rather than industry coming and saying, this is going to disrupt the whole of healthcare. That actually, I don't think people want healthcare to be disrupted in quite the way that some of the big digital industries would like to do so and have it sort of Uberized. And that's what people are frightened of. So quite often people, when you talk about digital mental health, it's as though people sort of assume there's a zero-sum game and everyone's going to be replaced. Therapists are going to be replaced by bots, and that's not the intention. The intention is just meeting population demand, and we're not going to be able to grow therapists on the sort of scale which is required. But to be able to scale it so that you've got something which actually dovetails with the more sort of the sort of therapeutic inputs you need for people who have very complex challenging conditions which require ongoing continuous care.
Thanks, Matthew. So despite all best efforts, I'm hearing that the Q&A channel isn't working. So we are going to go to the audience in one moment. And Brian Sagar, I'll bring you in just a sec. You've had your hands up for a little while. My apologies. But Till, if I could just go to you on I think the other obvious and important view here is that many, if not a good deal of these technologies allow and thereby contribute to revelation of mental health concerns and challenges. How do we equate this? How do we equate it in terms of clearly the enormous therapeutic, diagnostic, preventive potential, but they are also deemed as a vehicle that is exposing significant mental health concern. Your thoughts on that?
I think we need to divide up these technologies, the ones that are based on initially a theory that get developed, co-developed and co-produced. I think the one thing that and they're different from some of the digital technologies, say on the app stores, which are, which have never had any theory and have just produced nice pictures with an idea about need, but not necessarily knowing quite, having the evaluations. And I do think that part is a really important part, that we actually start with theory, we develop technologies that are likely to help, but we also need to be honest. So there is something called the number needed to treat. And if we were going to present our data, and it could have a significant effect on mental health, which might mean 6 out of 10 people are likely to improve. That still means that 4 people are unlikely to improve. We need to show that data to people who are going to use these digital technologies, because the negative effect of using something you thought would be helpful and then it turns out it wasn't for you will just feed back into their negative thoughts about themselves, which is likely to increase their mental health difficulties. And I think being honest with people is really important. I think there is a lot of discussion about how digital technology in general, rather than therapeutic digital technology, has negative effects on individuals. The data on that is haphazard, I think, in terms of words like being addicted to using a smartphone. And, I feel one of the questions in the addiction schedule is being anxious when you can't find your phone. Well, I'm anxious when I can't find my phone, and often I can't find it. In fact, when Matthew rang me at 5 o'clock, I couldn't find my phone. So I think we have to be careful about understanding what addiction might mean. But in terms of sort of bullying on social media or all those other ways in which digital technology can have negative effects, I think if people are bullied it provides some anonymization, and I think we do need to think about how we regulate that activity.
Look, thanks. I'm going to open up to the audience now, and what I would ask, we've got at least 5 folk who would like to ask a question. We've only got about 15 or so minutes left, so try and get your question across. If you want a particular member of the panel to respond to it, please do say. We've got a couple of questions, something we often give consideration to. Parish is concerned about sleep, digital therapies that can improve sleep. Who feels that they've got anything to offer here? Till?
There are evaluations of apps to help people with sleep, which seem to work. There's one called available to everybody and within the NHS, called Sleepio, and that's had several studies actually helping with that. There's been some other apps helping with sleep that also hoped, and this is a big hope, hoped to have helped with paranoia. And in fact, although there is a supposed link, they haven't actually managed to help with paranoia. So research using these apps is really important, because there may be claims made for, sleep will improve, your cognition. Well, it probably will improve your cognition, it will improve your mood, but it might not improve it enough to change some of the mental health problems that we have to deal with day by day.
Thanks, Till. Ed is really going to go for the futuristic view here. How far away are we from a digital twin of the person, of an individual thinking and behaviour, which can be used as a testbed to test mental health solutions? And through that, and then through a neural link, reprogram the brain to fix mental health issues. So Ed, fairly futuristic. Matthew, do you want to help bring us to where we are now, and whether in fact such approaches would be beneficial?
I would be kind of making stuff up if I was trying to answer that question seriously, and I'm not going to do that. I think we are some distance off. I guess there is a field of computational neuroscience which attempts to, in a much smaller, much more sort of focused and mechanistic way, attempts to understand, and model in silico what is going on from preclinical animal experiments in terms of brain functions. And I suppose there is that field, but actually that being applied to mental health or the sort of digital twinning with real, clarity about what's going on in the brain in these sorts of processes, I think we're a good way off. I have to say though that I'm quite happy to put up my arms and my hands and admit a degree of ignorance there. I don't know, Till, if you want to, or Faye, if you want to.
Well, if I may, until Faye, I'd like you perhaps to sort of something of a realistic element of an extension of this is, and Anand has put a question here, which specifically says, what's the present dialogue discussion around the use and the application of digital technologies as a means of manipulating behaviours more generally? And I suspect the view here is manipulating them in potentially, adverse ways. Faye, I mean, this does overlap a little bit around the ways in which, how folk cognate after face transplantation, which must be a very dramatic process.
Yeah, there is, there's certainly some interesting work that needs to be done on the ways in which we are able to incorporate a new external self into our notion of self. Absolutely. And those questions still have to be asked in lots of ways, particularly with people without sight. Because there are all kinds of questions that we just don't know about how the brain processes certain things. What I find very interesting about the questions, I think, from a historian's point of view or a cultural theorist's point of view, is the ways in which we often look for very narrow technical solutions to things or technological solutions to things. I'm thinking of the ways in which there's been a lot of discussion of Elon Musk recently and the neural implant, which is what the original question I think made reference to. And I think we need to have a lot more conversations about the sort of slow fix reality of a lot of mental health conditions that aren't simply about shifting something in the brain, but actually from the perspective of understanding the history of mental illness is much more about the circumstances in which people live that might give rise to those illnesses, including genetics and epigenetics and a more sort of holistic understanding. So whereas I can't speak specifically to the neural link, I do think the space there for a more holistic conversation about what we want to do with technology.
Till, any comment about the manipulation of behaviours? In other words, and I think the sentiment that Hannah's putting across here is going beyond what we might perceive therapeutic benefit to potentially changing behaviours that could be adverse, and how we control that.
I think going back, having a system where we could provide a therapeutic impact on behaviour in fact, with a digital twin would be really interesting. For instance, if we could, using big data, so maybe the clinical record interactive search system that we have at SLAM, and looking at the prediction of medication adherence, we might then be able to create digital twins of individuals, but of their behavior more than their thinking. I think thinking is missing out of this, because we generally, with data, we don't have what people are thinking at the time. But if we could think about how a person's behavior would predict that, or it could be encompassed in a digital twin, we might then think about how we should stratify those individuals to provide the ones who are likely to be non-adherent and have very negative effects, like in cardiovascular disease or in depression. We might then be able to provide a service to those people which would be therapeutically beneficial. We can't even do that now. So the idea, although that maybe not, you asked us about 5 years, I think that's at least another 15 years away. If we can't even do something positive, the idea of thinking about how to manipulate them in ways to do it negatively before we even have that big data. So we need to predict and then prevent something from happening, like preventing non-adherence, rather than predict and make people become, I don't know, a soldier or a mercenary or whatever the bad thing is that you want to change their behavior to. I think that is a long way off, actually.
Look, thanks. We'll be drawing to a close shortly, but amongst our alumni, we're a wide age range, and one of our members of the audience has asked very specifically, and we've talked about, access, we've talked about equity, but the question is, what research, or indeed currently available practical tools, are out there to assist an aging population to gain access to digital technologies, given, of course, the conversation we've been having and the risks that we might have a very significant cohort of folk who again, are denied access. So current ongoing research, or indeed some practical applications that are of relevance to an aging population. Matthew.
I mean, I mentioned the radar project, and actually there was a radar project on Alzheimer's led by my colleague Dag Arsland at the Institute. And so the idea was of being able to help people live better with dementia, for example, through the use of technologies. And it's not hard to sort of envisage a way in which that might happen, in terms of being able to support people, identify, if someone's had a fall, those sorts of fairly practical steps. I think one of the interesting things is, our assumptions around age and capability with digital, and I think there's a cohort effect. I think there are people in there, towards the end of their lives who may not be in a cohort who have been socialized into the use, but I think that there are a huge number of people in their 80s and 90s who make very, very good use of a smartphone and get their head around apps and use these as means of connecting, which are very very helpful in terms of health benefits, and so I think this is an area which, in quite simple practical terms, can have huge benefits. So it is about using, integrating that with the challenges people face, and again, I think potentially addressing what Faye's been talking about in terms of some of the experience of loneliness, which some of these technologies can be very effective in connecting people.
Yeah, Faye, and then I did want to just put a final question to you, Faye, but if you wanted to just pick up on that, I'd be grateful.
Yeah, just to add to Matthew's point, really, I think that what my research showed that a lot of the time it's actually trying to tailor the accessibility of digital technologies to the older population in a way that is often overlooked. So it's things like understanding hearing issues that may be undiagnosed, or understanding, you know, making things more visually accessible. So I think sometimes it's just there's a small step needed to give people the confidence to take on board new technologies. But also Matthew's point about loneliness, there's some really interesting work being done on robotic pets in care homes. And I'm looking at this with my new project around faces and facial expressions on robots. In the past, it's not been particularly successful in terms that people will prefer a warm-blooded animal like a real-life cat or a dog or a human to communicate with rather than a robot. But there's something about the ways in which the new technologies are developing around robotics that potentially has some interesting potential for care home use.
Well, although I was eager to get another question, and I think we are going to just about run out of time, and I'm sorry for that. And I'm sorry we've had some technical challenges, but we've had a great response from the audience. I'm going to not only thank the panel, but at this stage, I'm going to hand back to you, Jessica, as we draw to a close. But I certainly wanted to make sure I thank the audience for joining us tonight. Jessica.
Thank you, Richard. What an informative session we have had this evening, and thank you very much to our panel, Faye, Matthew and Till, for all volunteering your time to speak to us and share your research with us as well. And thank you to our audience for being so engaged and asking such interesting questions, and for bearing with us as we experienced technical issues. Teams gave us a little bit of a run around there, but we got there in the end and managed to get some really nice and interesting questions in. So I'm going to send an email to everybody on Monday in which I will link the recording of this webinar if you want to watch again or you'd like to share more widely as well, along with some information on our next webinar, which takes place on Tuesday, the 19th of March, and will explore artificial intelligence. So do make a note in your diary if you'd like to attend that one. I'd also like to flag that nominations are still open for our King's Distinguished Alumni Awards, and all King's alumni staff and students are eligible to nominate an alum for an award or share your own story and nominate yourself if you'd like to. We have a range of award categories in STEM, health, arts and culture, and many more, which recognise the achievements of our alumni community. Nominations for that close on Friday, the 9th of February, and I will share a link to that nominations form in the follow-up email as well. So do keep an eye out. And that's all from me. Thank you very much to everybody who's made this happen tonight, to our panel and our audience. And I hope you will enjoy the rest of your evening. Thank you.